The following program on cardiac auscultation contains heart sounds with very low frequencies and low intensities. These can be best heard when listening in a quiet environment and using a good pair of headphones with a frequency response down to about 20 Hz. To be sure your sound system is capable of reproducing the range of frequencies utilized, we are providing the subsequent test. Please listen to the following 3 tones. If you were unable to hear 3 distinct tones, you may not be able to hear an accurate reproduction of the heart sounds included within this CD. Cardiac Auscultation Pretest. For questions 18 through 25, listen to each of the heart sounds and identify it from the following list. Split first sound. Normal split second sound. S4. S3. S3 and S4 quadruple rhythm. Early systolic murmur, 1/6. Late systolic murmur. Diastolic murmur. 18. $19. $20. $21. $22. $23. $24. $25. Introduction. Cardiac auscultation is a skill with universal use and application. Regardless of the clinical setting or specialty interest, the practitioner will find that the ability to interpret the sounds generated by the heart will be invaluable. In this section, the basic concepts of heart sounds and murmurs will be introduced. The sounds you are about to hear represent a combination of mechanically replicated and real cardiac sounds. Inasmuch as the artificial sounds can be added and removed at will, they are used to permit the learner to develop a feel for the timing of each sound or murmur discussed. In order to familiarize the learner with the actual quality of each sound, real examples of normal and abnormal sounds and murmurs will be introduced where appropriate. In this way, the learning or reviewing of cardiac auscultation can be facilitated. Proficiency in cardiac auscultation can only be acquired through repetitive practice on a day-to-day basis. Normal first and second heart sounds. Listen to the following example. Normal first and second sounds can be heard. Each pair of sounds, lub-dub, lub-dub, will begin with the first sound and end with the second. Listen to these sounds and keep in mind the systolic and diastolic periods in the cardiac cycle. Normally, the first sound is slightly lower in pitch in comparison with the second sound. Production and components of the first sound. Although as many as 4 components of the first heart sound can be demonstrated by special recording techniques, the major audible components are related to mitral and tricuspid valve closure. Mitral M1 closure is the first audible component of the first sound. It normally occurs before tricuspid T1 closure and is of slightly higher intensity than T1. The mitral component is heard best at the apex, although it is discernible at any of the sites of auscultation. Since it is a high-frequency sound, it is heard best with the diaphragm firmly pressed. Tricuspid T1 closure is the second component of the first sound. It has less intensity behind its production and may only be audible at the left lateral sternal border. A split of the first sound occurs when both components that make up the sound are separately distinguishable. In a normally split first sound, the mitral and tricuspid components are 20 to 30 milliseconds apart. A split of the first sound is heard in about 70% of normal subjects and is heard best at the LLSB, with the diaphragm firmly pressed. Listen to a normally split first sound. Widely split first sound. Under certain conditions, a wide or abnormally split first sound can be heard. An abnormally wide split first sound can be due to either electrical or mechanical causes, which create asynchrony of the two ventricles. Some of the electrical causes may be right bundle branch block, premature ventricular beats, and ventricular tachycardia. More often, however, in actual practice, an apparently wide split will in fact be caused by another sound around the time of the first. A sound which can be mistaken for a wide split first is an ejection sound, which will be discussed later. Listen now to a widely split first sound. The intensity of the first sound is subject to considerable variation due to a variety of physiological factors, including 1. Chest wall shape and thickness. The thinner the chest, the louder the sound. 2. The rate of rise of ventricular pressure. The more energy behind ventricular contraction, the louder the sound. 3. The position of the mitral valve at the onset of ventricular systole. The wider open the mitral valve, the louder the sound. 4. The stiffness, i.e. calcification, of the AV valves. The stiffer the valve, the softer the sound. When the first sound is louder than the second, an impression of coming down the musical scale is perceived. When the first sound is softer than the second, the impression is that of going up the musical scale. Listen now to a loud first sound followed by a softer second sound. Now, listen to a softer first sound followed by a louder second sound. Production and components of the second sound. The closure of the aortic and pulmonic valves contribute to second sound production. In the normal sequence, the aortic valve closes before the pulmonic valve. A good rule of thumb to remember is that left-sided mechanical events normally precede right-sided events. The aortic, A2 component of the second sound is the loudest of the two components and is discernible at all auscultation sites, but especially well at the base. Since it is a high-frequency sound, it is best heard with the diaphragm of the chest piece firmly pressed. The pulmonic, P2 component of the second sound is the softer of the two components and is usually only audible at base left. Its high frequency is also best heard with the diaphragm of the chest piece firmly pressed. A physiological split occurs when both components of the second sound are separately distinguishable. Normally, this split sound is heard on inspiration and becomes single on expiration. The A2 and P2 components of the physiological split usually coincide or are less than 30 milliseconds apart during expiration and often move to around 50 to 60 milliseconds apart by the end of inspiration. The physiological split is heard during inspiration because it is during that respiratory cycle that intrathoracic pressure drops. This drop permits more blood to return to the right heart. The increased blood volume in the right ventricle results in a delayed pulmonic valve closure. At the same time, the capacity of the pulmonary vessels in the lung is increased, which results in a slight decrease in the blood volume returning to the left heart. With less blood in the left ventricle, its ejection takes less time, resulting in earlier closing of the aortic valve. Therefore, the net effect of inspiration is to cause aortic closure to occur earlier and pulmonary closure to occur later. Thus, a split second is heard during inspiration and a single second sound is heard during expiration. Listen to the following second sound. The second sound will be split upon inspiration and usually will be heard as single on expiration. The physiologic split second is heard best at base left with the diaphragm chest piece. The following example represents a second sound splitting interval of 25 milliseconds. Now, listen to a second sound splitting interval of 50 milliseconds. Now, listen to a second sound splitting at 75 milliseconds. The following example represents a normal individual with normal respiratory variation, or physiological splitting, of the second sound. The next example is also that of a normal individual. The recording is from base left. A physiological splitting is heard with each inspiration. Breath sounds are heard in the background. A reversed paradoxical split of the second sound occurs when there is a reversal of the normal closure sequence, with pulmonic closure occurring before aortic. During inspiration, the second sound is single, and during expiration, the second sound splits. This paradoxical splitting of the second sound may be heard when aortic closure is delayed, as in marked volume or pressure loads on the left ventricle, i.e., aortic stenosis, or with conduction defects, which delay left ventricular depolarization, i.e., left bundle branch block. Listen now to a paradoxically split second sound in a patient with left bundle branch block. Respiration is heard in the background. The split will be audible during expiration, and the second sound splitting will be narrow or become single during inspiration. The paradoxically split second sound is heard best at base left, with the diaphragm chest piece. Abnormally wide split second sound. The normal physiological split second sound can be accentuated by conditions that cause an abnormal delay in pulmonic valve closure. Such a delay may be due to increased volume in the right ventricle as compared with the left, atrial septal defect, or ventricular septal defect. Chronic right ventricular outflow obstruction, pulmonic stenosis, acute or chronic dilation of the right ventricle due to sudden rise in pulmonary artery pressure, pulmonary embolism, electrical delay or activation of the right ventricle, right bundle branch block, decreased elastic recoil of the pulmonary artery, idiopathic dilation of the pulmonary artery. The wide split has a duration of 40 to 50 milliseconds, compared to the normal physiologic split of 30 milliseconds. It is heard best at base left with the diaphragm. Listen to the following widely split second sound. The split will be taken out occasionally to allow you to compare the normal with the abnormal. Fixed splitting of the second sound. Fixed splitting of the second sound refers to split sound which displays little or no respiratory variation. The two components making up the sound occur in their normal sequence, but the ventricles are unable to change their volumes with respiration. This finding is typical in atrial septal defect, but is occasionally heard in congestive heart failure. The fixed split is heard best at base left with the diaphragm. The following example demonstrates a widely fixed split second sound. This was taken from a patient with an atrial septal defect. Concentrate only on the second sound and try to ignore the murmur which precedes it. The murmur will be discussed later. Fourth heart sound. The fourth heart sound is a low-frequency sound heard just before the first heart sound. usually preceding this sound by a longer interval than that separating the two components of the normal first sound. It has also been known as an atrial gallop, a presystolic gallop, and an S4 gallop. It is most commonly known as an S4. The S4 is a diastolic sound, which occurs during the late diastolic filling phase at the time when the atria contract. When the ventricles have a decreased compliance or are receiving an increased diastolic volume, they generate a low-frequency vibration, the S4. Some authorities believe the S4 may be normal in youth, but is seldom considered normal after the age of 20. The abnormal or pathological S4 is heard in primary myocardial disease, coronary artery disease, hypertension, and aortic and pulmonic stenosis. The S4 may have its origin in either the left or right heart. The S4 of left ventricular origin is best heard at the apex, with the patient supine or in the left lateral recumbent position. Its causes include severe hypertension, aortic stenosis, cardiomyopathies, and left ventricular myocardial infarctions. In association with ischemic heart disease, the S4 is often loudest during episodes of angina pectoris, or may occur early after an acute myocardial infarction, often becoming fainter as the patient improves. The S4 of right ventricular origin is best heard at the left lateral sternal border. It is usually accentuated with inspiration and may be due to pulmonary stenosis, pulmonary hypertension, or right ventricular myocardial infarction. Since the S4 is a low-frequency sound, it is best heard with the bell lightly held. Listen now to an S4. During the recording, the fourth sound will be removed and then added again. Now listen to an actual fourth heart sound, recorded from the apex of a 60-year-old male with cardiac disease. Now compare the timing and quality of the S4 with that of a split first sound. First, the S4. And now, the split first sound. Third heart sound. The third heart sound is also of low frequency, but it is heard just after the second heart sound. It occurs in early diastole, during the time of rapid ventricular filling. This sound occurs about 140 to 160 milliseconds after the second sound. The S3 is often heard in normal children or young adults, but when heard in individuals over the age of 40, it usually reflects cardiac disease characterized by ventricular dilatation, decreased systolic function, and elevated ventricular diastolic filling pressure. Its nomenclature includes the term ventricular gallop, protodiastolic gallop, S3 gallop, or the more common S3. When normal, it is referred to as a physiological third heart sound and is usually not heard past the age of 40. The abnormal or pathological third heart sound may be heard in individuals with coronary artery disease, cardiomyopathies, incompetent valves, left to right shunts, ventricular septal defect, VSD, or patent ductus arteriosus, PDA. The pathological S3 may be the first clinical sign of congestive heart failure. The S3 may have its origin in either left or right heart. The S3 of left ventricular origin is best heard at the apex. The S3 of right ventricular origin is best heard at the left lateral sternal border. The S3's low frequency is best heard with the bell lightly held. Both S3 and S4 increase with exertion and become fainter with the patient sitting or standing. Third heart sounds are often associated with sharp outward precordial movements, which frequently can be seen or felt. Listen to the following S3. The third sound will be taken out occasionally to enable you to determine its position in the cardiac cycle. The following example demonstrates an S3 in a patient manifesting congestive heart failure. Since the heart rate is rapid, one of the first compensatory mechanisms of failure, one has the impression that there are 3 sounds with each cardiac cycle. Quadruple Rhythm Summation Gallop. When both the third heart sound and a fourth heart sound are present, with a normal heart rate, 60 to 100 heartbeats per minute, the 4-sound cadence of a quadruple rhythm may be heard. Listen to such a rhythm in which all 4 heart sounds are present. Now, listen to all 4 sounds taken at the apex of an elderly male patient with heart disease. At a rapid rate, S3 and S4 may occur simultaneously and are heard as a very loud diastolic sound, known as a summation gallop. The gallop sound falls midway between the second sound and the first sound of the next beat. Listen as a summation gallop is added in the presence of a rapid heart rate. Ejection sounds. Ejection sounds are high-frequency, clicky sounds occurring shortly after the first sound with the onset of ventricular ejection. They are produced by the opening of the semilunar valves, aortic or pulmonic, either when one of these valves is diseased or when ejection is rapid through a normal valve. They are heard best at the base and may be of either aortic or pulmonic origin. Ejection sounds of aortic origin often radiate widely and may be heard anywhere on a straight line from the base right to the apex. Aortic ejection sounds are most typically heard in patients with valvular aortic stenosis, but are occasionally heard in various other conditions, such as aortic insufficiency, coarctation of the aorta, or aneurysm of the ascending aorta. Ejection sounds of pulmonic origin are heard anywhere on a straight line from base left, where they are usually best heard, to the epigastrium. Pulmonic ejection sounds are typically heard in pulmonic stenosis, but may be encountered in pulmonary hypertension, atrial septal defects, ASD, or in conditions causing enlargement of the pulmonary artery. Both aortic and pulmonary ejection sounds are heard best with the diaphragm firmly pressed. Listen now to an ejection sound. The following example was taken from a patient with mild aortic stenosis. Mid-systolic, non-ejection clicks. Clicks are high-frequency sounds which occur in systole, either mid, early, or late. The click generally occurs at least 100 milliseconds after the first sound. The most common cause of the click is mitral valve prolapse. The clicks of mitral origin are best heard at the apex, or toward the left lateral sternal border. The click will move closer to the first sound when volume to the ventricle is reduced, as occurs in standing or the Valsalva maneuver. When ventricular volume is increased, as in squatting or bradycardia, the click will move farther from S1. Listen now as a click is introduced during systole and then withdrawn. The next example is that of a normal 20-year-old female with a typical mid-systolic click. Opening snap. The opening snap is a short, high-frequency sound, which occurs after the second heart sound in early diastole. It usually follows the second sound by about 60 to 100 milliseconds. It is most frequently the result of the sudden arrest of the opening of the mitral valve, occurring in mitral stenosis, but may also be encountered in conditions producing increased flow through this valve, i.e., VSD or PDA. It is best heard between the apex and the left lateral sternal border, with the diaphragm of the chest piece firmly pressed. In tricuspid stenosis, or in association with increased flow across the tricuspid valve, as in ASD, a tricuspid opening snap may be heard. The tricuspid opening snap is loudest at the left lateral sternal border and becomes louder with inspiration. The following example was recorded from the apex of a patient with mitral stenosis. Now, compare a split-second sound to that of the opening snap. Note that the interval of the second sound split is narrower, about 30 milliseconds, than the distance between the S2 and the opening snap, 60 to 100 milliseconds. The split second. Now the opening snap. Let's also contrast the opening snap to a third heart sound. Note that the S3 follows the second sound by a longer interval and is lower in pitch than the opening snap. The opening snap. Now, the third heart sound. The opening snap is best heard with the diaphragm firmly pressed, while the S3 is best heard with the bell lightly held. Murmurs. By definition, murmurs are sustained noises that are audible during the time periods of systole, diastole, or both. They are basically produced by these factors. 1. Backward regurgitation through a leaking valve or septal defect. 2. Forward flow through a narrowed or deformed valve or conduit or through an arterial venous connection. 3. High rate of blood flow through a normal or abnormal valve. 4. Vibration of loose structures within the heart, i.e., chordae tendineae or valvular tissue. Murmurs that occur when the ventricles are contracting, that is, during systole, are referred to as systolic murmurs. Murmurs occurring when the ventricles are relaxed and filling, that is, during diastole, are referred to as diastolic murmurs. Initially, there are 6 characteristics which you should consider in murmur identification and differentiation. 1. Location, or the valve area over which the murmur is best heard. This is one clue to the origin of the murmur. Murmurs of mitral origin are usually best heard at the apex. Tricuspid murmurs at the lower left lateral sternal border, and pulmonic murmurs at base left. Aortic systolic murmurs are best heard at base right, and aortic diastolic murmurs at Erb's point, the third intercostal space to the left of the sternum. 2. Frequency, pitch, low, medium, or high. 3. Intensity. Use the 1 to 6 grading system. 4. Quality. Blowing, harsh, rough, or rumbling. 5. Timing. Occurring during systole, diastole, or both. 6. Radiation. Areas where the sound is audible in addition to the area over which it is heard best. 2 additional characteristics may be considered as you become more adept at auscultation. These are 1. Finer timing, determining if murmur occurs early, mid, or late during systole or diastole. 2. Other changes related to respiration, position, special maneuvers, or drugs. Systolic murmurs. By definition, systolic murmurs are sustained noises that are audible during the time period of systole, or the period between S1 and S2. Forward flow across the aortic or pulmonic valves, or regurgitant flow from the mitral or tricuspid valve may produce a systolic murmur. Systolic murmurs may be normal and can represent normal blood flow, i.e., thin chest, babies, and children, or increased blood flow, i.e., pregnant women. Early systolic murmur. Early systolic murmurs begin with or shortly after the first sound and peak in the first third of systole. Early murmurs have the greatest intensity in the early part of the cycle. The commonest cause is the innocent murmur of childhood, to be discussed later. A small ventricular septal defect, VSD, occasionally causes an early systolic murmur. The early systolic murmur of a small VSD begins with S1 and stops in mid-systole, because as ejection continues and the ventricular size decreases, the small defect is sealed shut, causing the murmur to soften or cease. This murmur is characteristic of the type of children's VSD located in the muscular portion of the ventricular septum. This defect may disappear with age. This next example presents such a murmur. Listen next to the sounds taken from a 20-year-old female with a small muscular VSD. The recording was taken at the left lateral sternal border. Mid-Systolic Murmur. A mid-systolic murmur begins shortly after the first sound, peaks in the middle of systole, and does not quite extend to the second sound. It is the crescendo-decrescendo murmur, which builds up and decreases symmetrically. It is also known as an ejection murmur. It most commonly is due to forward blood flow through a normal, narrow, or irregular valve, i.e., aortic or pulmonic stenosis. The murmur begins when the pressure in the respective ventricle exceeds the aortic or pulmonary arterial pressure. The most characteristic feature of this murmur is its cessation before the second sound, thus leaving this latter sound identifiable as a discrete entity. This type of murmur is commonly heard in normal individuals, particularly in the young, who usually have increased blood volumes flowing over normal valves. In this setting, the murmur is usually short, with its peak intensity early in systole, and is soft, seldom over 2/6 in intensity. It is then designated as an innocent murmur. In order for a murmur to be classified as innocent, i.e., normal, the following must be present. 1. Normal splitting of the second sound together with absence of abnormal sounds or murmurs, such as ejection sounds, diastolic murmurs, etc. 2. Normal jugular venous and carotid pulses. 3. Normal precordial pulsations or palpation. And 4. Normal chest X-ray and ECG. Obstruction or stenosis across the aortic or pulmonic valves also may give rise to a murmur of this type. These murmurs are usually longer and louder than the innocent murmur and reach a peak intensity in mid-systole. The murmur of aortic stenosis is harsh in quality and is heard equally well with either the bell or the diaphragm. It is heard best at base right and radiates to the apex and to the neck bilaterally. The murmur of pulmonic stenosis is less common. Its harsh quality is also heard equally well with either the bell or the diaphragm. It is heard best at base left and radiates along the left sternal border. Listen now to a typical mid-systolic murmur. Note carefully the fact that the murmur diminishes clearly before the second sound. Now listen to a normal individual with an innocent systolic ejection murmur. The next example is the murmur typical of severe aortic stenosis. Contrast that with another innocent murmur as heard in a 2-year-old child. Severe aortic stenosis. Now, the 2-year-old child. In the next example, an ejection click will be introduced, and then a systolic ejection murmur will be added. Now the murmur will be added. Late systolic murmur. A late systolic murmur begins in the latter half of systole, peaks in the later third of systole, and extends to the second sound. It is a modified regurgitant murmur with a backward flow through an incompetent valve, usually the mitral valve. It is commonly heard in mitral valve prolapse and is usually high in frequency, blowing in quality, and heard best with the diaphragm at the apex. It may radiate to the axilla or left sternal border. The following example will display such a late systolic murmur. The murmur will be added and then removed from the cycle. The next example is that of a late systolic murmur in a patient with a mitral valve prolapse. Now the mid-systolic click is added. Now, a late systolic murmur is added. Now the click is removed. Now the murmur is removed. Pansystolic or holosystolic murmur. A pansystolic or holosystolic murmur is heard continuously throughout systole. It begins with the first heart sound and ends with the second heart sound. It is commonly heard in mitral regurgitation, tricuspid regurgitation, and ventricular septal defect. This type of murmur is caused by backward blood flow. Since the pressure remains higher throughout systole in the ejecting chamber than in the receiving chamber, the murmur is continuous throughout systole. The following recording will introduce a pansystolic murmur having an even intensity throughout systole. The next example will demonstrate the actual sounds from a patient with mitral regurgitation. In this example, note the rather high frequency of the murmur, a characteristic commonly encountered in this condition. Diastolic murmurs. Diastolic murmurs are sustained noises that are audible between S2 and the next S1. Unlike systolic murmurs, diastolic murmurs should usually be considered pathological and not normal. Typical abnormalities causing diastolic murmurs are aortic regurgitation, pulmonic regurgitation, mitral stenosis, and tricuspid stenosis. The timing of diastolic murmurs is the primary concern of this program. These murmurs can be early, mid, late, and pan in nature. Early diastolic murmur. An early diastolic murmur begins with a second sound and peaks in the first third of diastole. Common causes are aortic regurgitation and pulmonic regurgitation. The early diastolic murmur of aortic regurgitation usually has a high-frequency blowing quality, is heard best with the diaphragm at Erb's point, and radiates downward along the left sternal border. The following example is that of an early diastolic murmur taken from a man with mild aortic regurgitation. The murmur of pulmonic regurgitation occurs after a slight delay after P2. It has a rough quality, which is heard best with the bell lightly held at base left, and radiates along the left sternal border. The murmur of pulmonic regurgitation tends to be of short duration and heard best on inspiration. This respiratory variation is helpful in differentiating pulmonic regurgitation from aortic regurgitation. Mid-Diastolic Murmur. A mid-diastolic murmur begins after the second sound and peaks in mid-diastole. Common causes are mitral stenosis and tricuspid stenosis. The murmur of mitral stenosis is a low-frequency, crescendo-decrescendo rumble, heard at the apex with the bell lightly held. If it radiates, it does so minimally to the axilla. Mitral stenosis normally produces three distinct abnormalities which can be heard. 1. A loud first sound. 2. An opening snap. And 3. A mid-diastolic rumble with a late diastolic accentuation. The following example will present each feature of mitral stenosis. A loud first sound is followed by a mid-diastolic murmur. The murmur will be introduced after the first few cycles. Now, a pre-systolic accentuation is added, followed by an addition of an opening snap. Now the early portion of the diastolic murmur will be eliminated, leaving only the pre-systolic portion. Now the murmur is removed, leaving the opening snap. The diastolic murmur of tricuspid stenosis is similar to that of mitral stenosis, except that it is heard best at the left lateral sternal border and may radiate to the apex or the xiphoid. Late diastolic murmur. A late diastolic murmur occurs in the latter half of diastole, synchronous with atrial contraction, and extends to the first sound. Although occasionally occurring alone, it is usually a component of the longer diastolic murmur of mitral stenosis or tricuspid stenosis. This murmur is low in frequency and rumbling in quality. It is best heard with the bell lightly held. Listen to a late diastolic murmur. Continuous murmur. A continuous murmur usually begins during systole and extends through the second sound and throughout the diastolic period. It is usually produced as a result of one of four mechanisms. 1. An abnormal communication between an artery and vein. 2. An abnormal communication between the aorta and the right side of the heart, or with the left atrium. 3. An abnormal increase in flow or constriction in an artery. And 4. Increased or turbulent blood flow through veins. Patent ductus arteriosus, PDA, is the classical example of this murmur. This condition is usually corrected in childhood. It is heard best at base left and is usually easily audible with the bell or diaphragm. Another example of a continuous murmur is the so-called venous hum. But in this instance, one hears a constant roaring sound, which changes little with the cardiac cycle. Now, listen to the typical murmur of patent ductus arteriosus recorded at base left. Pericardial friction rub. In a pericardial friction rub, there are 3 sounds, 1 systolic and 2 diastolic. The systolic sound may occur anywhere in systole, and the 2 diastolic sounds occur at the times the ventricles are stretched. This stretching occurs in early diastole and at the end of diastole. The pericardial friction rub has a scratching, grating, or squeaking leathery quality. It tends to be high in frequency and best heard with a diaphragm. A pericardial friction rub is a sign of pericardial inflammation and may be heard in infective pericarditis, in myocardial infarction, following cardiac surgery, trauma, and in autoimmune problems such as rheumatic fever. They are frequently best heard at the left lateral sternal border, with a patient leaning forward or lying supine in deep expiration. To simulate a pericardial friction rub, grasp the diaphragm of the stethoscope in the palm of your hand, and then rub the back of that hand with the finger of your other hand. The following example displays a typical friction rub recorded at the left sternal border of a male with pericarditis. Both the systolic and diastolic components of the rub are heard. Cardiac auscultation post-test. For questions 18 through 25, listen to each of the heart sounds and identify it from the following list. Wide split S2, normal split S1, S3. Pansystolic Murmur. Opening snap. Diastolic rumble. Summation gallop. Ejection click. 18. 19. 20. 21. 22. 23. 24. 25.